this leads me on to what I have called in my paper here, the ladder of refraction. Let's put it like this. You have a 25-year-old patient, -3, 4, whatever, perfect for laser, for LASIK. You LASIK the patient with a good method, a stable method. Patient comes back every year for regular controls, of course monitoring the IOP very carefully. At 40, oops, it doesn't work anymore. The patient is getting presbyopic. So there you stand in front of two doors. If the eye is healthy, right, shall I go or opt for Presby LASIK, or shall I opt for the new thing, as we've heard Juan talk about today, Presby eye drops? Let's continue up the ladder at 65. Oops, I'm having cataracts. How do you see? Up to 40, no problem. I would like to ask the panel their view on which road to take. What will your options for correction be after the age of 40? First question. Second question is, at the age of 65, when we have cataracts, where do I go from there? Now, please look ahead into the future. And I think we start with our friend from Japan.
I see. Okay, I'm an ortho specialist. So my best answer is to take ortho. And as for me, I'm 45 years old, and I am a patient of ortho. I designed by myself for my myopia, and my myopia is 6 and 7 diopter also. Now I have a monovision, left eye almost plano, and right eye almost 1 to 2 diopters. So I can see well distant and near, and so I will provide the knowledge of the ortho for the patients, younger age and elder patients. And to my clinic, some patient who had LASIK 12 years ago or 15 years ago, and but when he took the LASIK surgery at the age of 30, but he is now 42 or 45, and he had difficulty to see near vision. I can treat such a case with using the ortho treatment, very specific design. So ortho has a great possibility to get good visual acuity for rehabilitation of some other surgical treatment. But 65, at age 65, I do recommend the cataract surgery with correcting myopia or hyperopia. That is the best way to presbyopia correction for higher elder age patients.
Thank you. Johan?
For me, the first and foremost factor is, like Aristotle said, first, do no damage. And if you are 40 and you're happy to use monovision, that's fine. Contact lenses, it's fine. Presby drops, it's fine. And you can continue using that until you're 60. For myself, monovision doesn't work for me, but I will try the drops. I will definitely not allow anybody to touch my cornea, because things change. And we did our case in the 80s, and we know how many problems we have today as a result of the R case. And if you look at a new treatment that is irreversible, and you think, maybe 10 years down the line, this guy will not be as happy as he's going to be for the first 2-3 years, then you should not do it. So, for me, the bottom line is reversibility. And then when you get to 60, 65, I've got many happy patients with multifocal IOLs, and I'm not very impressed with multifocal IOLs, but many patients are. So if you eliminate the wrong cases and you do the right cases, it works. And the other thing is, it's reversible. If it really goes bad, you can take out that lens. I've unfortunately happened to take out a few lenses, not many, but I took out a lens or two. So reversibility and do no damage for me are the bottom line.
Thank you. Salvador?
Well, this patient is a very good patient because he's very happy. And I think he's very happy because 10 years ago, I completely changed his quality of life. So this patient comes to me with 3 diopters of myopia. I operate him, and every year he's in my clinic telling me I'm very happy until the presbyopia arrives. We need to think in terms of quality of life for this patient, because it's the first thing he knows of us, and it's the reason of his happiness. So perhaps the first option for me would be the Presby drops. Is a good option to increase the quality of life and not to damage. I don't have experience of Presby drops, so I don't know if we can achieve 65 years old with Presby drops. If we can, it's a good thing to pass from the presbyopes to an multifocal IOL. If we can't, if at 50 years old, 55 years old, we will not have enough effect of these drops, then we can think about another solutions, perhaps in cornea, perhaps laser solutions. There's a patient who was already treated by laser, and he knows this. If we can arrive to a multifocal IOL, well, I think that my patients with multifocal IOLs are much more happier and have a better quality of life than my patients with multifocal spectacles. That's what I think.
Thank you. Juan?
Okay, I was talking like a patient, because in the past I used to begin to use less for reading 3 years ago, and then I, like John, didn't like any laser, anything in my eyes, only the glasses. But since 1 year ago with Dr. Benosi, I began to use the drops for myself. And I am very happy because they are very, very simple, very easy, and I think that for the 40 to 50 until to 60 years old is a good option. After that, sure, if you become cataract, I prefer introduce a multifocal lens and take out the cataract. It's my recipe for now.
Thank you. Surya?
Thank you. I think you said initially a patient that had LASIK several years ago and now has become presbyopic, right? That leads into what I'll be talking about later today, and that is there's delayed presbyopia in patients after LASIK and PRK, and the reason for that delay is because the corneal surface has actually become, as time goes on, slightly multifocal in these patients. Now, going on from there, I'd just like to digress for a moment and talk about myself. Why? Because when I started to become presbyopic, I'm much older than I look, by the way, much older. When I started to become presbyopic, I tried monovision, and I could not adapt to monovision. The lenses was not a problem, but I could not adapt to monovision, period. I tried various multifocal soft contact lenses, which are on the market, couldn't tolerate them. I felt a fool because for many years I've been fitting bifocal and multifocal contact lenses and convincing patient this is a good way forward, fitting RGP lenses, bifocal types and multifocal types for many, many years. But when it came to myself, I couldn't make it work for me, okay? So unlike our good friend from Japan, I cannot self-abuse by putting the rigid lenses on myself and making them work, but he can do it, okay? So, going from there, that's why I'm stuck with these glasses, because this is only things working and my distance prescription isn't that high. But what happened is that in the last 5 years, I've started to develop significant amounts of astigmatism in one eye. Now, if I had had Presby LASIK, say 5 years ago, I would have a vision problem right now because this astigmatism is starting to develop in one eye. So even if we do certain corneal procedures, the patient's lens, the rest of the optics of their eyes are still changing. So what do? I think we need to have a technique which is less invasive and possibly reversible. And I know we talked about the Presby drops today, but I think this is a very, very viable option for patients that have already had corneal refractive therapy. And also, it's cost-effective compared with ortho-key lenses. Maybe in Japan it's a little bit better, but I think it would be more cost-effective in Europe and the rest of the world. So I think for the relatively young presbyope, I think we should go for the drops. Once they start to develop cataracts, so that becomes a significant problem, then we stop the drops and go into the appropriate kind of lens options for post-op for the cataract patients.
Frank.
Okay, your question is a very good question, but when we want to answer in detail, it will take us a whole day.
I know.
Or a book of 500 pages. So some ideas. Indeed.
A summary.
A summary, not a whole book. When you are before such a patient, first the psychology of your patient. What does he want? Does he want something to help him out for a few years? Will he eventually support the drops? Is he willing to put it every day? Or does he want a final solution? And then again, what's the refractive state? Is he a hyperope or a myope? Because we know when you put a lens in a myope, in all lenses they will have PCO, we have to yak them, and for myopes there is still the risk of a retinal detachment. For hyperopes there is no risk. So there are different facts to consider. Of course, when he has a cataract, when he's 65 years old, we have to discuss with him what does he want, what are his hobbies and so on. So the drops may be an excellent solution for some people to help them out during several years. But we have to see if it's supported and what are the side effects. Will they be able to drive at night, etc., etc.
Thank you. Now, Dr. Benuzzi, we'd like to hear your view on my hypothetical patient.